using Slido.com. To join Slido, please type Slido.com in your browser. Once in Slido, type the event code #connect. The event code is not case sensitive. You may then send in your questions through Slido Q&A tab at any time during the program. At the end of this meeting, you may also answer the feedback form using Slido. Please fill out the feedback form and then Stefan Jacob.
Good morning, everyone. I hope you had a good night's sleep and are ready and filled with energy for the next day. We had a very interesting sessions yesterday with Dr. Camillo talking to us about the cardiovascular disease prevention, with Merlin Thomas showing us what we can do to prevent the eggs from getting disturbed and broken. Remember the eggs and the kidney, how we can protect the kidney. And then we had a case discussion all together with Dr. Wu as well. And with you, interesting discussions. And let me just quickly wrap up a couple of points. We learned that type 2 diabetes is much more than glucose. It's a cardiorenal metabolic disease, and it has a high rate of complications. It's a cardiovascular disease risk equivalent. And if we really want to prevent the complications, which we could do, we have to start early, and we have to be very intensified broadly to correct all the risk factors, as we learned from the STENO2 trial and the Swedish registry. And then we need to focus more to detect the risk. And we did, for instance, talk about my case, in which we did discuss that it's not just enough to focus on glucose, but we should also look whether there is end organ damage. And we, for instance, discussed the UACR, EGFR, and the other risk factors which frequently are forgotten when we handle our patients. And then we learned that there's clear evidence for the use of SGLT2 inhibitor, in particular in people with very high risk, because it decreases the hospitalization for heart failure, it improves CKD and mortality, and we discussed that we should give this drug as early as possible because we want to bring these advantages to our patients as early as possible. And then, unfortunately, these data are not really translated into patient care. And I think this is a call for action. We really need to get going and bring this knowledge to our patients. And we have to prescribe the drug, because only if we prescribe the drug can exert the benefits. I mentioned yesterday a British study, and I just want to share with you the results again. These are newly detected type 2 diabetic patients. And when you look at those people who had been followed for a couple of years, you see that at the time of diagnosis, 40% had already microvascular disease and 30% already had macrovascular disease. That tells us that in our daily routine, when we have patients showing up the first time with diabetes, we really need to check, because it could well be that there are already pathologies which call for more intensified actions. And I think this has been a little bit overseen in the past. So now we go on, and we will talk about how we should start and step up early. Professor Wu is giving us his lecture, and this is followed by and then expert consult, and then case discussions, and your questions and answers. And then I will call Dr. Wu to start with his presentation. Thank you.
Thank you, Professor Stefan Jakob. We bring the scientific session to a start with the presentation, Start and Step Up Early in Type 2 Diabetes, by Senior Staff Specialist Endocrinologist and Director of the Diabetes Center at the Royal Prince Alfred Hospital in Sydney, Australia, Dr. Ted Wu.
Okay, good morning everybody. It's great to see you all here this morning. Thank you very much to Stefan for his expert chairmanship so far, and I hope that we're going to have another fantastic session today. So today I'm going to be talking about starting and stepping up early in type 2 diabetes. Here are my disclosures, and we'll get right into it by reflecting on the fact that yesterday we were talking a lot about the cardio, renal, and metabolic system as a linked triad of pathologies and therefore complications that we want to help to prevent for our patients with diabetes. Type 2 diabetes is only one part of this, and in order to most effectively treat patients with type 2 diabetes, we need to be thinking about the cardiac system and the renal system, as well as the glucose or metabolic system as well. And as we reflected yesterday, it is fantastic that we have a molecule such as empagliflozin, which has been shown to have marked reduction in 3-point MACE, in nephropathy in the EMPA-REG outcome study, and also in its 2 heart failure studies to reduce heart failure outcomes in both reduced and preserved ejection fraction heart failure. So as we were saying yesterday, empagliflozin is now considered a foundational therapy in type 2 diabetes, not only because it reduces blood sugar effectively, not only because it reduces weight, but because it targets all of these complications that patients dread and we want to prevent for our patients. However, let's not forget that diabetes is also about high sugars. It's not the only thing. We don't want to be sugarologists, as Stefan has said. But the thing is that even if we cover the risk factors such as hypertension, dyslipidemia, and use empagliflozin in terms of glucose lowering, sometimes the glucose lowering is not enough, or the glucose control is initially there, but then unfortunately type 2 diabetes does progress. And this is some data extrapolated from the UK PDS, showing that for every 1% reduction of HbA1c that was achieved by patients, that lower limb amputations were reduced by 43%, microvascular disease, and that of course includes kidney disease, reduces by 37%, cataracts by 19%, but more significantly, heart failure, AMI, and stroke were reduced by 12 to 16%. Now that's for 1% reduction in HbA1c. For further reductions in HbA1c, we get cumulative benefits. So even going down from an HbA1c from 10 to 9%, although the patient has not reached target, is still beneficial for the patient. However, it is difficult. As clinicians, I'm sure you are all aware, it is hard to reach glycemic control for a prolonged period of time for the majority of our patients. At any given stage of time, on the left-hand side, you can see that only a minority, about 1/3 of patients, will be reaching the usual glycemic target of HbA1c 7% or less. And this is because longer duration of diabetes leads to poorer glycemic control. On the right-hand side, you can see that when adjusted for time, at 3 years, 44% may be reaching target, but by the time that you reach 9 years of disease duration, you're at 13% of the population of type 2 diabetes reaching glycemic targets. So it gets more and more difficult over time to keep patients under good glycemic control. And you may have good glycemic control at one point, but then it gets worse over time. So what can we do? Yes, metformin is at the start. SGLT2, such as empagliflozin, as we pointed out yesterday, are foundational therapies. But a very good third-line option is DPP4 inhibition, because they're tablets. They're easy to take. They have very few side effects, but they are complementary in terms of mode of action with SGLT2 inhibitors. In fact, if we think about it in combination with metformin, the combination of metformin plus SGLT2 plus DPP4 inhibitors targets 7 out of the 8 pathophysiologies of type 2 diabetes, and therefore is very effective in bringing down blood sugars. And we can see that in this trial, which compared the combination, the fixed dose combination of empagliflozin plus linagliptin in the red squares, you would always get better HbA1c outcomes than those who were taking either empagliflozin in the green or linagliptin in the orange. Of course, it makes sense. 2 agents are better than 1. And you can see that in people who were reaching target, the majority of people taking EMPA and LINA were reaching target, whereas the only minority of people taking either EMPA or linagliptin were reaching targets. But even more pleasingly, if the HbA1c was greater than 8.5% at baseline, then the combination of empagliflozin and linagliptin, that we know as Glyxambi, was able to, on average, bring down HbA1c by 1.84%. That's very powerful blood sugar lowering. And in fact, if you started at 8.7% and the average HbA1c lowering was 1.84%, well, you are more than likely to reach target for your patients. So the combination of empagliflozin plus linagliptin in a fixed dose combination tablet makes sense because it's very effective in bringing down blood sugars. But what about what we were talking about yesterday? The complications, the cardiac and the renal complications. We know that empagliflozin certainly reduces things like heart failure, things like CV death, things like renal outcomes. What about linagliptin? Well, we haven't talked too much about the outcome studies of the DPP4 inhibitors because they're mostly neutral. But in this case, neutral is not too bad. At least we know it's not like rosiglitazone, which increased some of the adverse cardiac endpoints. So looking a little bit further, we can see the comparison. The EMPA-REG outcome on the left-hand side certainly reduced 3-point MACE, but in the CARMELINA study for linagliptin, we were able to show that linagliptin is perfectly safe for the cardiovascular system. And so therefore, in combination, we can expect the empagliflozin, the benefits of empagliflozin, to be consistent when giving Glyxambi. And this is reflected in the ADA consensus statement, ADA EASD consensus statement. The very first thing that we need to consider are the complications and the cardiac risk factors. In this case, they're asking about, does the patient have high risk of ASCVD? If so, use either GLP-1 or SGLT2, such as empagliflozin. But then down here, if the HbA1c remains high, then consider other safe therapies such as linagliptin. So this combination of metformin followed by empagliflozin, followed then by linagliptin, if the HbA1c is still high, makes sense and is advocated for by the ADA and EASD consensus statement. In terms of heart failure, I think it's even more important, because while empagliflozin had a 35% reduction in hospitalization for heart failure EMPA-REG outcome, in the CARMELINA study, linagliptin was shown to have a trend but not significant reduction in hospitalization for heart failure. Hazard ratio 0.9, p-value was 0.26. But why am I pointing this out? It is because other DPP4 inhibitors, specifically saxagliptin and to a lesser extent alogliptin, had safety signals in terms of hospitalization for heart failure. However, we can see that linagliptin, if anything, had a trend towards reduction in hospitalization for heart failure. So it's perfectly safe. Now, there are only 2 fixed-dose combinations of SGLT2 plus DPP4 inhibitors that are available on the market. You either have EMPA plus LINA, or you have DAPA plus SAXA. And if you're going to be using dapagliflozin because you're trying to reduce heart failure, It doesn't make much sense to then combine it with a DPP-4 inhibitor that might increase heart failure. So the only sensible thing is to use a DPP-4 that is perfectly safe for heart failure, and that is linagliptin. Perfectly safe for heart failure. And you do not reduce that benefit that we're seeing from the empagliflozin. So once again, the ADA EASD consensus statement says that if the patient either has heart failure or is at high risk of heart failure, the foundational therapies are metformin plus empagliflozin. And then if the HbA1c remains high, then we should add something safe like linagliptin. So we've talked about the cardiac system and the metabolic system. What about the renal system? The renal system, I won't go too long about this. We already know that the renal system is very, very important. If you have CKD, you are at very high risk of heart disease. You're at very high risk of heart failure. You're at very high risk of hospitalization for any cause. Once you develop kidney disease, then things get worse. And people don't necessarily die on a dialysis machine. They will die mostly of a cardiovascular complication if they have diabetes and kidney disease. So we want to prevent kidney disease. We've seen some of this data, the EMPA-KIDNEY study of empagliflozin 10 milligrams versus placebo in a very wide range of kidney disease, both in type 2 diabetes and without type 2 diabetes, showed very clear benefits in terms of empagliflozin. I mean, the hazard ratio of 0.72 with that p-value of 0.001, highly statistically significant, with a number needed to treat only 28. I mean, that's a massive benefit for empagliflozin. But what about linagliptin? Well, in terms of, well, there's the EMPA-KIDNEY showing that there's very good outcomes for the kidneys, but in terms of preventing kidney disease, well, glucose control is still very important. The microvascular complications, and nephropathy is a microvascular complications, are very strongly linked to glucose control. Here's some of the big glucose control trials: intensive glucose control versus non-intensive glucose control. And in the ACCORD and ADVANCE studies, in the single studies, you can see that intensive glucose control was associated with a direct reduction in kidney outcomes. In terms of UKPDS and VADT, there was less of an outcome just for kidneys, but for microvascular disease in general, there was definite reduction in the strategy of glucose control. And taken overall in meta-analysis, the overall outcome is that yes, glucose control is very much associated with a reduction in kidney outcomes. So while being on empagliflozin is fantastic foundational therapy to reduce the risk of complications, if the sugar is still high, that equals residual risk of developing kidney disease. And it's just like blood pressure tablets. If someone's blood pressure is high, they are at risk of kidney disease, of course. And if we place them on ACE-ARB, that reduces their risk. But what if the blood pressure is still high? What if the blood pressure is still 150 on 90 and they're on ACE-ARB? Of course, you must treat the blood pressure as a target with other therapies, such as thiazide diuretics or calcium channel blockers or even beta blockers, etc., to help reduce that risk of kidney disease further. And it's the same with glycemia. The most important thing is to use very effective agents, such as empagliflozin, to reduce the risk of renal disease. But if the blood sugar remains high, you still have to treat the blood sugar to reduce that risk further. And so what do we know about the safety of linagliptin? Well, in the CARMELINA study, there was absolute renal safety. In fact, there was a reduction in albuminuria, but albuminuria is a somewhat soft renal endpoint. These are hard renal endpoints, such as development of end-stage kidney disease or doubling of serum creatinine. And in those cases, well, linagliptin doesn't impact those things, but still has a positive impact on albuminuria. So if we can combine empagliflozin with linagliptin, again, we preserve the renal benefits of empagliflozin with linagliptin, which helps to reduce the sugar further and therefore reduce the risk of microvascular disease. Again, going back to the ADA-EASD consensus statement, when CKD is of primary concern, use SGLT2s primarily with good evidence, i.e. something like empagliflozin, and then if the HbA1c remains high, then add something that's safe, such as linagliptin, to reduce the blood sugars further. Weight loss. Weight loss is, of course, of increasing importance, even in the Asian populations where previously weight wasn't considered such a big issue. We know that weight loss of 5% or greater leads to reductions in not just blood glucose, but also in blood pressure, independently of any other mechanism, of any other medications, and an increase in HDL and reduction in triglycerides. All very, very good. And we know that empagliflozin, which is in the blue, helps to reduce weight. Well, if you combine empagliflozin plus linagliptin in Glyxambi, that weight reduction is preserved. So we are not using anything. I mean, linagliptin by itself is fairly weight neutral, but when you combine linagliptin plus empagliflozin, you are preserving that weight loss of 2.5 to 3 kilograms that we see with empagliflozin alone. So going back to the ADA-EASD consensus statement, when we are trying to minimize weight gain or even weight loss, yes, GLP-1s are best for weight loss, but SGLT2s are not bad either with 2 or 3 kilograms of weight loss on average. And then if GLP-1 is not tolerated, consider adding a DPP-4. So this combination of SGLT2 plus DPP-4, in this case, I'm advocating for empagliflozin and linagliptin, is, of course, a very sensible choice. But what about hypoglycemia? Whenever we reduce blood glucose, in the past, especially when I was training a very long time ago, we were always afraid of hypoglycemia because sulfonylurea and insulin, although very effective in bringing down blood sugars, unfortunately, we ran into the barrier of hypoglycemia. But isn't it great to see that either empagliflozin or linagliptin alone has a very low rate of hypoglycemia, in fact, the same as placebo. And then the combination of empagliflozin plus linagliptin, even though you're getting a better glucose outcome, you're still having this placebo-like rate of hypoglycemia. In fact, we now say, if you're combining EMPA, Lina, and metformin, you are essentially at zero risk of severe hypoglycemia. Everybody, even those people without any medications, can sometimes go a little bit hypo, especially if we're fasting and exercising. So, of course, this is a placebo-like level of hypoglycemia. And going back to the consensus statement, if our main aim is to minimize hypoglycemia as a complication, then DPP-4 and SGLT2, such as empagliflozin and linagliptin, makes perfect sense. So, yesterday we were discussing in the case that holistic approaches to management are very important. And you can see here that EMPA plus Lina is very good in terms of the holistic approach. We're not just being sugarologists. We're not just reducing sugar. We are reducing sugar in a sensible way, in a way that reduces cardiorenal risk with empagliflozin and not increasing cardiorenal risk by using something like linagliptin on top of it. And at the same time, we're not increasing weight gain, and we are not increasing hypoglycemia. And so I would have to say that empagliflozin plus linagliptin is a very, very important escalation tool if we are not achieving good glucose control with metformin and empagliflozin as a combination in type 2 diabetes. Using EMPA plus Lina makes sense not just physiologically and pharmacologically, but also practically as well. It's available in a small tablet. It's easy to take. It's once a day. And very importantly, the cost of Glyxambi is less than purchasing empagliflozin and linagliptin separately, which makes this form of therapy very accessible to a wide range of patients. So I will conclude that once again, let's not forget that the complications of things like heart failure, kidney disease, and cardiac disease is first and foremost what we want to prevent. So we want to use something effective that's proven like empagliflozin. But glucose control is still important to reduce the risk, to reduce the residual risk of these complications. And lowering the glucose further will help to reduce the risk. And using something safe, effective, and easy to take, such as Glyxambi, which combines empagliflozin and the best-in-class DPP-4 linagliptin, is something that I think is very, very sensible. Thank you very much for listening.
Thank you, Dr. Ted Wu. Please stay with us a while longer for the Experts Consult with Professor Stefan Yacob.
All right, thank you very much for that very nice talk. We do have a problem out there in the field because people do have safety concerns still with the SGLT2 inhibitors. How would you handle that? What is your comment to that?
Okay, that's a very good point, Stefan, and I think that came out very clearly in the questions and answers yesterday. A lot of the questions were around safety. And I'm not going to pretend that there's no concerns. Almost every effective medication has some degree of adverse effects. But it's our knowledge of those adverse effects that helps us to prevent them and helps us to use these medications safely. I completely share the audience's concern about safety because that is the only way that we can safely, obviously, treat our patients and to prevent adverse outcomes. So in terms of SGLT2 inhibitors, and especially when we think about starting early, I think starting early is a good point. Because when the sugar is very high, if you're starting with an HbA1c of 11 or 12% when thinking about starting an SGLT2, in fact, that can lead to side effects in and of itself. You may get more polyuria. You may get more thrush because there's more glycosuria. So in fact, starting early with an SGLT2 already will decrease the risk of adverse effects. The other thing to realize about the adverse effects of SGLT2s are that they're very easily manageable. By far the most common adverse effect are those genital fungal infections, such as thrush that we were talking about. In the clinical trials, this was found to be about in 5% of patients. But then when you look even closer, only about 1% stopped due to these issues. And not even the whole of those 1% was due to thrush. So very few patients actually have thrush that is so troublesome that they have to stop. The way to manage it is with simple over-the-counter medications that you can get from any pharmacy, but also the advice to have good hygiene and to watch out and treat the symptoms early will help to prevent the cessation of the medications. And I think you yourself said yesterday, the patients can see the benefits so early that even if they come back and have thrush, for me, I say, well, do you want to stop this medication? And they often say, no, I don't want to stop. I can see that this is a very effective medicine for me. My sugar has gone down. My weight has gone down. I'm taking less insulin.
Yep.
It's fantastic.
Yep. And I think this is very, very important because, first of all, it's very reassuring when you look into the trials that there's a very low dropout rate due to these side effects. My personal experience, I have been working with the SGLT2 inhibitors now for more than 15 years in the preclinical studies and so on. And I was very much worried about the same thing. And I was surprised that the rates were very low. And in the papers, you see the dropout rate, as you just said, is very, very low. Most of my patients go back on the drug again because they like it. It's easy. They don't have to measure glucose. They don't have to observe how many carbs they eat. They should eat carbs. We talked about that yesterday. But they don't have to really weigh out the carb units and everything as they would have to do with insulin. And it's very convenient. You take it once a day.
Now, in terms of the other side effects, polyuria, although often talked about, is much less of an issue, especially, as we say, if you're starting at a reasonable HbA1c. So please start early. We find that the combination of loop diuretics, such as furosemide and SGLT2s, may cause more polyuria. There's controversy amongst cardiologists of whether we should proactively reduce the dose, or if the patient has uncontrolled heart failure, well, maybe we shouldn't reduce the dose, but I'm always a little cautious. Thiazides, I don't find to be too much of an issue. And to be perfectly honest, I very rarely see polyuria as an issue that people come back with. I think that the other one these are more common side effects, but they're actually quite minor in terms of impact on the patient. Of course, the thing that you're all worried about is ketoacidosis. So we've talked about the very low carb diets. We've also talked yesterday about stopping the SGLT2s whenever the patient is acutely ill, especially if they're not eating and drinking normally, and stopping 3 days before any planned procedure. If you follow these steps, you can avoid the vast majority of cases of DKA. And although the DKA may be severe, the thing to watch out for is that the sugar may be lower than you expect. You can sometimes have high sugar as well, but you can have DKA in these patients with the sugar of 7 or 8. You don't have to, sorry, that's not in milligrams per deciliter. That's in
140,
millimoles.
150.
We have to
140,
but
150.
it can be normal or euglycemic diabetic ketoacidosis. You can avoid the vast majority of these, however. If you are aware of it, if you give the information sheet, much as Stefan and I do, then really it is not much of an issue at all. And it is actually so rare that it took us many years. I mean, as you say, we've been using it in clinical trials for more than 10 years, and it took us I think it was about 6 or 7 years into the usage before we found the signal. That's how rare it is. Okay, so it's there. And I'm not pretending it's not an issue, but it's not something that you're going to see every day, especially if you warn the patients.
And just one anecdote, my patient, a couple of patients thought that they had to go to the toilet much more often. And they said, I'm not going to take this drug because I have to go to the toilet all the time. And I said, hey, okay, just stop the drug for 3 days and make a list how often you go to the toilet. And 2 days later, he came back and said, you were right. I was wrong. And it's not that there is an increase in voiding. There's no worry about that. I think that if you need to convince the patient, just do that little trick and you will see. Let's move on. I mean, you have talked about Glyxambi and the combination. And I do find that quite helpful if we have one single pill with 2 different components. Very frequently, we have to fight with our patients about adding another medication. So what would be the patient suitable for initiation of additional combination therapy?
Yeah, that's a very good question. And I'm going to have to say, I don't have a hard and fast rule. And even the guideline bodies can't agree either. Some guidelines, if we take ADA versus AACE, some will say, if your HbA1c is greater than 9%, you should start immediately on combination therapy. Some say if you're greater than 7.5%, you should start immediately on combination therapy. In fact, it is different for different patients. And the higher the HbA1c, the more likely that somebody will need combination therapy sooner rather than later. This all goes back to the concept of clinical inertia. I think that there's not too much to be lost to be saying, well, I'm going to start metformin, but if after only a couple of months the blood sugar is not coming down, I'm going to give them empagliflozin straight after that. And then don't wait too long. Wait maximum 3 months. If the HbA1c hasn't come down then, add that third thing. Add the DPP-4. Change them from Jardiance to Glyxambi. Because the last thing you want is for the patient to be dragging on for years and years and years with an HbA1c that goes up and up and up each time you see them. And before you know it, the HbA1c is 10%. So clinical inertia is unfortunately easy. It's easy for clinicians. It's easy for patients. Because not changing anything is the easier thing to do. Oh, I promise I will eat better, doctor. I promise that I'll do more exercise. But how often does that happen? The thing is that we don't have to say, I'm going to start combination therapy right here on day 1. If you're starting it within 3 to 6 months, I think that's perfectly fine. Don't let it drag on for too long.
Well, in particular, as we don't have to worry about hypoglycemia, as you said, I think this is the point which made it so difficult to initiate an aggressive glycemic management. And the people can even do the lifestyle changes and everything because they don't have to worry about going into hypoglycemia as they would with an SU or with insulin. All right. Well, Thank you so much. I think we're gonna have time now for question and answers. And if you have a burning question, just put it in the Slido and we will get the questions on our tablet. And so now we are calling the next two speakers to come and help us answer the questions.
Up next is a case discussion highlighting the need to start and step up early. Professor Jacob and Dr. Du will be joined by clinician scientist and program leader at the Department of Diabetes at Monash University in Australia, Professor Merlin Thomas, and interventional cardiologist and chairman of the Department of Internal Medicine at Hospital ng Maynila Medical Center, Dr. Camilo Aquino.
So now we are ready for the next questions. And can we have the questions someplace?
Case study first.
Oh, the case study first. Oh, okay, sorry. Yeah, okay.
So we are going to do a case study now. This is not a very complex case study, but I hope that this case reflects what we were just talking about in my talk and also in the questions and answers. So this is based on a real person that I saw, not in my major teaching hospital in the city, but this is in the country. This is in the country, New South Wales, which is about a 1 hour airplane flight or 5 hours driving. This is a rural community, so they are often not as well serviced as people in the city, but this person was not too badly off. Look, when I saw him, he was 61 and he's a part-time accountant, so he's transitioning into retirement. He has had type 2 diabetes for 9 years, and because of that, I'm going to start this case what happened 9 years ago when he was 52. So when he was 52, he was diagnosed, and at that time the HbA1c was 8.6% and his BMI was 29. Okay, that's actually not too bad for this area. In this area of Australia, there are many, many people with obesity, unfortunately. Now, he was initially started on metformin 500 milligrams twice a day, and of course lifestyle, because we cannot forget the lifestyle interventions. And he initially had a good response with HbA1c. It went down to 6.6%. His BMI also went down a little bit to 27 after 1 year. He took the lifestyle advice on board. Now, what I forgot to put in this slide was that we actually had to up-titrate the metformin. The metformin eventually had to go to 1,000 milligrams twice a day in order to achieve that HbA1c. So please don't forget, he is on essentially the maximum dose of metformin, 1,000 milligrams twice a day. Now, he has a family history of cardiac disease, but the cardiac disease manifested in his family relatively late in life, in the 70s or so. So I wasn't too concerned about that. I'm much more concerned when people tell me about a family history of heart disease that manifests in the 30s or 40s. Now, of course, that is still a bad thing. It is not great to have a family history of ASCVD, and especially so because he has hypertension and dyslipidemia himself. So at that visit, I made sure that he was on an ARB or ACE, and he was indeed on telmisartan. I increased it to 80 milligrams, and he was on atorvastatin, 40 milligrams, so a moderate intensity of statin therapy. I mean,
This looks like a diabetes success story, doesn't it?
at the moment, it certainly is.
This is great, isn't it? Great A1C, recognizes risk of blood pressure. This is fantastic.
Lifestyle.
This is exactly what you want to do in the old days.
That's right. And really, he was on the good end of the spectrum. He really took the messages on board, and not everybody is like this. So I didn't have a magic wand. He was actually a pretty good patient. But even though he was a, inverted commas, good patient, 4 years after that time, look at that, the HbA1c increased to 7.8% despite maximal metformin. The BMI increased back up to the baseline, 28. We often see this. The eGFR, not too bad, 82, but the ACR is raised. So it was 63. And the blood pressure, 135 on 80. So not fantastic either. Now, I discussed a few options with him. I discussed DPP-4, I discussed SGLT2, I discussed GLP-1. Fortunately, in Australia, we have equal access to all of these medications at a subsidized rate for people on metformin. Now, he worked as an accountant with no specific job-related issues. You know, out in the country, I have a lot of truck drivers, for example, and they say to me, I don't want to go and rest stops to go to the toilet all the time. Not that it's that big an issue, but it sometimes does crop up. There was nothing like, you know, a person working in construction or something like that. However, he did say to me, I'd rather not have an injection. Okay. So we agreed, and even 4 years ago, the best evidence at the time was that he really, out of DPP-4 and SGLT2, should start an SGLT2. So I started him on empagliflozin. Now you can see here that I started 25 milligrams. And remember the question yesterday, do we start on 10 or 25? As I said, I don't think this is a wrong dose, but an HbA1c of 7.8%, I'm already thinking I'm going to use 25%. That's the most likely dose to get him down to target. Okay? The high dose will get you slightly more HbA1c lowering and slightly more weight lowering. So I just went for the full dose. And also, we didn't mention this, the side effects of 10 milligrams versus 25 milligrams is exactly the same in every single clinical trial. So it's not as if we're getting more side effects by starting at 25 milligrams. And that is why I often start at 25 milligrams.
Did you use a fixed dose combination?
My preferred option is to start with the separate tablets, and then when they tolerate it, I go to the fixed dose. Just because it's easier, just in case there's a side effect, I can quickly take it off and just go back to the metformin, I'm going to add something else. Yeah. That's just my preference. Now
Well,
look
actually,
at this.
I also do the same thing, because the patient then can tell me whether he tolerates that added on medication. Usually I prescribe a small package only, and then the patient comes back after 3 to 4 weeks, and then I prescribe the fixed dose if necessary.
And it's not so confusing, you know, oh, I'm going to add this and it has this in it and that in it. Oh, but we're going to switch you back because it will take this one away. It's much easier to go isolated, as you say.
Yeah.
It is this one that is causing the problem, maybe. Okay, so he is a success story. Look at what happened when I introduced empagliflozin. And this was a real case, 6.7%. The BMI went back down to 27, okay? The eGFR, look, it went from 82 to 77. But was I worried? No. And if there's one thing that I would like you all to remember is that the drop in eGFR, especially a small drop like this, is not a worry. In fact, I often tell the patients, this is a sign that the medicine is working. It's taking the load off your kidneys. I don't say it in these words, but what's going on in my mind is that the intraglomerular pressure is decreasing. Therefore, the GFR is decreasing. Therefore, we are decreasing the load, the strain on the glomeruli. So I'm absolutely not worried about a drop of eGFR of 5 at all.
But wouldn't your patient ask you, why is my creatinine going up?
Well, that's if the patient realizes that. They have to ask, well, what's that? What's that number? So sometimes they do. And in fact, I find that patients increasingly are aware of their kidney function. So yes, I do have to describe it, and I do then describe it in these sort of terms to the patients, that we are actually decreasing the strain on the kidney, and that this is exactly what we expect. And this is backed up by the slight reduction in ACR, which is still above normal, but has decreased a little bit. Now remember, ACR does go up and down a little bit, but in this case, it did go down.
And I think it's really an opportunity, when the patient opens up this issue, it's an opportunity for us to again pound the message that we are actually protecting the kidneys and even the heart of this patient. So in the long run, the patient will really derive the benefit the most as time goes by, as patients taking the medication.
Absolutely. So look, success story. And I think that I hope that all of you have seen cases like this, where empagliflozin can have very good effects on all of these things. Oh, and the blood pressure as well. Look, the blood pressure went down by 5. That's absolutely typical as well. So it won't go down by 10. So Camilo said yesterday, you won't get double digits falls, but you can certainly get 5 millimeters of mercury. That's very common to see. However, just as I was saying before, type 2 diabetes is a progressive disease. So when I saw him earlier this year, of course, he's now 61. Right? He's now 9 years post-diagnosis, 4 years since starting the empagliflozin, and HbA1c has gone up again, 7.5%. The disease has progressed. The BMI has remained stable. I mean, he's trying as hard as he can to keep his BMI stable. The EGFR has, about the same, 79. So it goes up and down. 79 is still pretty good, right? ACR is 38, so it's gone down a bit, but as I say, it does go up and down. Blood pressure is pretty good, okay? So his cardiac and renal factors are stable. But what's gone up? His HbA1c. So at this point, we're going to open up, I believe, the word cloud again. We're going to do the word cloud. And what are your thoughts for Eric? Was a success story. He's done very well on metformin plus EMPA. But now there is a problem. The HbA1c has increased, but fortunately, his other cardio-renal risk factors seem to be well controlled. I didn't mention it, but it's not just the blood pressure. The lipids aren't too bad either.
Good.
While they're keying their words, I think we need to also remember that we really need to screen for any symptoms for any potential cardiovascular manifestations, because failure to do so will, of course, miss the opportunity for us to intervene early. And when you say intervene early, as Professor Merlin was emphasizing, to really focus on the optimal medical therapy quite early. So maybe, is there a need for an antiplatelet right now? Is there a need to have an add-on therapy, for example, to lower the LDL further? These are potential added concerns and may not be an important issue for as long as patients wouldn't have additional risk factors and symptoms, of course.
Good. I see the DPP4 is popping up quite frequently. I think you did a good job.
But I'm very glad to see that lifestyle and reducing stress and checking diet is still there. Okay, don't don't think that all we're doing here is say add DPP4, add more tablets. We must think about the whole of patient approach. But I'm glad to see that the DPP4 and Glyxambi.
I have one issue, and I'm a little bit provocative. We are just deciding to prescribe a drug without even knowing anything about his glucose profile. We have never ever talked about that. We just finished a PhD where we checked diabetes management in Germany, and we did find out that most of the patients who are not on the CGMS, they're very rarely measuring glucose, and very rarely it's done in a structured way. Because in that guy, what I would love to have, and my patients need to do this twice before they come to me, I want to have a 7-point glucose profile. Pre-breakfast, 2 hours post-breakfast, pre-lunch, post-lunch, and so on, and then before they go to bed. And then I get an idea, is that a preprandial problem or is that a postprandial problem? And very frequently, at least in Europe, you see that the people start out with a horrible fasting glucose. And this is not because in the night the glucose went up, because they went to bed with 250, because they had too many apples, they had too many snacks. And I think if we talk about diet, we really have to consider that. And 6 or 7 test strips just for diagnostic purposes, it's money, even, I mean, yeah, but it gives you a good information about metabolism and the food habits as well.
Yes, absolutely. So targeting diet, it's not just one diet fits all. Targeting what is the problem with the diet is very important. And without that information, you won't know it.
Yeah. In Australia, we have what's called, in this situation, it's called the stop rule. And what we would do in this sort of situation, before we cross the road to the DP4 inhibitor, we would look both ways.
Yep.
And it's really lovely that it's on there, but it's really important to go, one of the major reasons that you lose glucose control is non-adherence, whether to diet, lifestyle, or medication. And obviously, that's not going to be fixed by a new pill.
Yep.
You have to look at the reasons why this individual is not getting control. It may turn out to be, well, this is the natural history of beta cells, that they're losing their function over time, and that's understandable. But there may be other reasons. It might have been the steroids that he was taking for lung disease. It might have been intercurrent infections or the lack of mobility because his knee's giving out. And as a result, he's less active. So there may be understandable reasons that they may be fixable more directly, like he needs an orthopedic surgeon to fix his knee, and then that would solve his A1C. Or another really important one in men who are about to retire is major depression. Yeah. Is that often men retiring, got chronic diseases, diabetes, increases the risk of depression and anxiety. And what do you do in those situations? You become non-adherent with all sorts of different things. You binge eat, whatever. So there's all sorts of different reasons that may underlie it. So before you cross the road, and I'm not sure you're going to go to a DP4 inhibitor, just remember the stop rule to look both ways and see what else is going on in this individual, because that's always an important thing. And there's sometimes a really important reason that you can fix directly rather than saying the solution is another drug.
Very good. And there's one thing I learned by CGM with my patients. In Germany, we are a little bit, let's say, in a better situation because the people are more ready to pay $60 to get this CGM for one single shot. And I do this like a 24-hour ECG, and I have them 2 weeks put on that to see how glucose moves in the night and during exercise. It's very instructive for them. And in several of my patients, I did find out that despite the fact that during the whole day glucose was good, at breakfast there were always terrible peaks. And it turned out that they always took the glucose medication after they had breakfast. And I think this is something we need to also rule out, because if we are giving metformin, and especially a DPP-4 inhibitor and an SGLT2 inhibitor taken after I had breakfast, they will only be reabsorbed much, much later. So that's why you get a peak, and that ruins a little bit the glucose control during the day. So start to talk about that as well. So, sorry.
Yeah, absolutely. And look, it's actually there. Adherence there, in the word cloud. So fantastic. Thank you very much for all of those
But also that when you talk about personalizing the care, it's like not just he's got IA1C, whatever, I do that for everybody, but personalizing it to their glucose profile, the kind of person they are, the kind of positives that they get out of life, the kind of needs that they have, whether they're a truck driver or not. Personalized care is the way to adherence and actually hitting targets.
Yep.
Well, if we move on, let's see what happened. So he still prefers tablets. And I did discuss a GLP-1 with him because that is very much standard of care in Australia to be thinking about a GLP-1 in this instance. But he really did prefer DPP-4. And in this case, I thought, well, yeah, obviously add linagliptin. And for convenience sake, I went straight to the fixed dose combination because in this case, I was confident that adding linagliptin would not add to any side effects. Linagliptin is one of those few medications with literally no side effects. So went straight to the fixed dose combination. And what was the result? Well, the HbA1c is only just under 6.9. I'm sure next time I see him, it might be a little bit higher. But look, the result has been very good. And I was happy enough with his situation. Simply changing the Jardiance to Glixambi.
Yeah, great. And we would have to stick with him closely because at the moment HbA1c is still okay, but I think he is, as we just discussed, we need to individualize and we need to look, because I would guess that there are a couple of things in his diet which will be a little bit lousier once HbA1c is good, because he says, oh, I made it, and then he's not observing the diet as good as he should, and then within the next 3 to 6 months, you will see an increase again, which is due to the lack of efforts in lifestyle.
And I don't think he'd be smiling this way, this patient, if you'd put him on a sulfonylurea back after his metformin failed.
Yeah.
You know, he would have been even more non-adherent because he'd worried about his hypos. His weight would have been higher. His GFR, which you notice is relatively stable over the last number of years, someone with microalbuminuria would have declined around about 2 mils per minute per year, so that now 9 years after his diagnosis of diabetes, he would be, you know, well below 70 instead of being 79. So he would have been tracking down, whereas you've stabilized him out. And if you stay on this medication, it's likely that in the future, this guy will never end up with renal problems. Whereas with the sulfonylurea, he would have been going down and down and down and getting fatter and getting more albuminuria, more kidney disease. You've changed his trajectory by a very, very simple choice right at the beginning to use an agent that's not only well tolerated and easy to adhere to, but also effective in terms of protecting that vulnerable egg of the kidney overall.
I do have a question to the cardiologist, because I think that guy is the typical guy which is also prone for cardiovascular disease in terms of family history, hypertension. What are your thoughts about, should we send him to you? Should we just handle optimal medical therapy as aggressively as we can?
That's why I mentioned the need for really asking for all symptoms related to cardiovascular conditions, because, as we said, it's a coronary heart disease risk equivalent. So we always have to screen. Doing at least an ECG will potentially reveal something. If it's normal, doesn't necessarily mean it's normal, but we continually have to monitor this patient for any early signs of a cardiovascular condition. But I won't go to the extent of sending this patient, asymptomatic one, to an angiogram, for example. I think it's crucial that we are able to really provide a more comprehensive risk reduction strategy. It has to focus on being able to really lower the LDL on target and being able to lower the blood pressure. In fact, 130/80, it can be debatable. We want to bring it a little closer to 120. You can argue against it. You can argue in favor of being a little bit more aggressive. But I think the main important concern now is really being able to avoid all the sequelae of diabetes. So not only cardiovascular, even the renal complication.
Okay, I heard the time is up, but just one last burning question. Would you give aspirin to this guy? Because that's a question I always get in Germany.
I won't start.
You won't?
I wouldn't.
If he gets a statin because he's got high cardiovascular risk, he deserves an aspirin.
Yeah. So, but what happened to Eric then?
Did you do a calcium score on his coronaries?
No, I didn't do a calcium score. It's a bit difficult to do that in rural New South Wales, unfortunately.
If he was downtown in Sydney, would you have considered that in terms of trying to really hone in on his risk?
Yeah, I might consider that if he was in the city, yes.
Would you briefly conclude, or?
Well, very briefly, I think that Eric demonstrates that metformin is very good. Empagliflozin is now foundational therapy to reduce the cardiorenal risk in someone with a high ACR. Remember, that's the real trigger point here. He had a slightly raised ACR. But if he has high HbA1c after starting this foundational therapy, he still has residual risk. So let's think about getting the HbA1c down safely and easily, and adding something like linagliptin would be a very good way to do that.
Thank you very much.
Thank you very much to our panel of speakers. The next 20 minutes will be dedicated to an open forum. You may continue to send your questions via Slido. In your browser, go to slido.com and simply type the event code #connect and then proceed to the Q&A tab. Please welcome back Professor Stefan Jacob, Dr. Ted Wu, Professor Merlin Thomas, and Dr. Camilo Aquino.
All right. Yeah, let's start out. I've got already a couple of questions. Will taking Clexambi will have less genital infections compared to taking EMPA alone? That's a quite interesting question.
Yeah, it's an interesting question because I suppose one way to approach it is that the linagliptin doesn't modify the risk of genital fungal infections very much. So on the first cut of the thinking about it, you go, no, it won't change it. However, the truth of the matter is that by decreasing the blood sugar with the linagliptin, you decrease glycosuria. And by decreasing glycosuria, you can expect slightly less genital fungal infection.
Okay.
It certainly would not increase it.
Yep.
It might decrease it, but not to a great extent, not that you might notice.
Okay. Any comment? No? All right. EMPA may be given in hepatic patients. Can we give empagliflozin to patients with liver cirrhosis? And if EMPA is given to certain liver cirrhosis patients, which stage of liver cirrhosis can we give?
Well, in patients with severe liver disease like liver cirrhosis, of course, you've got many things on your mind apart from glycemic control. They're in deep water. One of the problems with severe liver disease is that they also have major cardiovascular risks, and the major causes of death associated with severe liver disease are a cardiovascular event or acute kidney injury where they get really dry because of low albumins and things like that. So cardiovascular disease, acute kidney injury, it makes actually a lot of sense to be on an agent like empagliflozin. What you'll also find is that you have to be a little careful when they get dry or if they got sick or were going to surgery or whatever. But in those situations, you can use empagliflozin and you can use linagliptin very effectively in that setting, and has been used, for example, in some liver transplant patients who have got obviously on steroids and other kinds of things where you need good glucose control and you don't want to be using insulin. So it can be used, but you have to do it cautiously.
I'd go even further than that, but go backwards a little bit. You know, SGLT2s, just like GLP-1s, have been studied in the treatment of MAFLD, okay, or NAFLD. So that it's not just the weight lowering, but there's some other effects that SGLT2s and GLP-1s have that can decrease the risk of progression of liver disease. So there's increasing research. We haven't got the final answers yet, but there will, I believe, be increasing use of both SGLT2s and GLP-1s to treat MAFLD and to reduce the progression of MAFLD. When you talk about end-stage liver disease, well, that's a whole nother question altogether. And unfortunately, SGLT2s have not been studied in clinical trials in end-stage liver disease.
But I think this is an important issue we just touched upon yesterday as well, that MAFLD, metabolic associated liver disease, should be taken as early as possible also into consideration. So we should really check for the FIB-4 score at least once a year, or at least at the time of diagnosis, and then every other year if it's normal, because the concern is that the people move on to the liver cirrhosis. Can we give SGLT2 inhibitor as a first-line therapy to people with a low HbA1c of 6.8 instead of metformin? This is the cardiologist.
I remember when the ESC had a statement on this, right? A bit controversial, but a bit brave as well. A thought-provoking recommendation of maybe in patients who are not receiving metformin yet, that you can actually bypass metformin, more particularly so in a patient who is really at risk for heart failure. Maybe we can modify that patient at risk for CKD because of the new data. I think it can be done. In fact, it modified also the other guidelines like that of that ADA and the ASD, that it's now looking at presence of ASCVD risk, heart failure risk, CKD risk, to really identify all of this risk and be able to identify these kinds of patients who needs and warrants to receive SGLT2 inhibitors or a GLP-1 receptor agonist. So I think it is very possible.
You wouldn't do it for glucose lowering. I mean, SGLT2 inhibitors don't lower glucose when there's no glucose in the bloodstream.
Yeah.
But because you've got some risks like your cardiac, and heart failure, and renal risks, that is the reason for putting it on board and ticking that box.
And that's why there's a statement there, irrespective of the A1C, right?
Yeah, yeah. There's only one little thing, at least in Europe, still following the SMPC, we still have to start somehow with metformin. And you might get into a reimbursement issue in Europe because they are strict on that still, because metformin is cheap and they want to have that first.
Unless you're using it for another indication, not diabetes.
Yes.
So if you're using it for treat heart failure or cardiac risk or CKD, when you get the indication here in the Philippines, obviously you don't have to worry about the A1C because you can use it in non-diabetic individuals.
Right.
Yeah.
But that's also a little bit confusing for some of the doctors in Germany because you have the indication for CHD, for heart failure, for CKD, and for sugar lowering. And people have been used to just use it for sugar lowering. They're confused now with the different indications, the limitations with EGFR.
Just on that point of the ordering, in Australia it's very similar. Metformin is still the first line, and then something like an SGLT2 is second line. But one thing that we don't have in Australia is timing. So they never say how long. So perhaps you could say, I give you metformin and tomorrow I'm going to give you the Jardiance on top of that. So
it's almost the Italian way. Bypass the rules. Okay, let's move on. What are some parameters to titrate EMPA from 10 to a higher dose? Do we primarily look at the glucose levels only?
Yes, that's the primary thing. So there's no difference in terms of cardiac outcomes. There's no difference in terms of renal outcomes. There's no difference in terms of side effects between 10 and 25. The only difference is glucose lowering and weight lowering. So you're absolutely right, whoever asked that question. If you are not getting adequate glucose results from 10 milligrams, go up to 25. That's basically it.
All right. Another question. Good morning. Will you re-challenge empagliflozin in a male patient with recurrent balanitis and not keen for sexually transmitted disease screening? Who wants to take that?
I think the key word here is recurrent. Okay. So we were saying that things like genital fungal infections are usually easily treatable and usually manageable. However, once it becomes recurrent and troublesome, then we would have to think about something else, I believe. And what you don't want is for this to become a more serious genital fungal infection. So, as I said, the key word here is recurrent. How recurrent was it? How severe was it?
How educated he is in genital hygiene.
Yeah, actually, I must say I had patients who had a circumcision because they had severe phimosis, and that was causing the balanitis. After surgery, it was all gone. Now we have another question for Dr. Ted. Would you start empagliflozin alone to a newly diagnosed patient with type 2 diabetes and an HbA1c above 10?
Well, that goes back to that question of metformin. So, in fact, the easy answer is yes. I start metformin plus Empalina pretty much straight away. I think that's
There's one word of caution, I must say. We tend to forget the TINT, treatment-induced neuropathy, and retinopathy if we lower glucose too harsh in a short period of time. This is individualizing treatment, because I have seen patients who had newly diagnosed diabetes and totally changed their food. They gave up carbs, and with the medication I started at that time with metformin and DPP-4 as a combination treatment, they dropped from an HbA1c of 12 to down to 6 within 3 months. And I was worried about that, and I had a patient who had the treatment-induced neuropathy, because if you have a severe drop in the glucose after having been flushed with glucose in all the tissues, that can cause trouble. So you might have to talk to the patient about how to handle that.
One of the nice things about an SGLT2 inhibitor is, of course, as your glucose comes down, the glucose lowering effect sort of lowers as well. And so you come in for a bit of a softer landing than you had to do with other kind of medications. But just like Ted suggests, that the combination therapy early for those with high A1Cs is exactly what the AACE suggests, the American College of Endocrinologists, that you know you're going to need more than one agent if you're going to A1C above 10. You know that that's going to be the case. So starting on one and then waiting 6 months before you start another, and it's time wasted and potentially kidney function, cardiac function wasted. You may as well get on with what you know that you're going to need, which is combination therapy early.
Then there's an interesting question following up. Again, someone with a high HbA1c, would you immediately start SGLT2 to a patient with an HbA1c above 9% and has catabolic symptoms? Or should we try to lower glucose with other agents and then reintroduce an SGLT2 inhibitor?
That's an interesting question, and I think the basis of that question is, well, why do people get catabolic symptoms with a high HbA1c? And that's because of calorific loss from glycosuria. Okay? So SGLT2 is going to increase the glycosuria, and the person who's asked that question is absolutely correct. Perhaps now is not the time to make that glycosuria much more in terms of magnitude, and therefore maybe increase catabolic symptoms. We do have many options. That's one of the great things about diabetes. You know, it causes confusion sometimes, but the other thing, the positive side, is that there are many options. So you've got metformin, you've got DPP-4, even sulfonylureas could be used in these sort of instances. But the thing is, get them onto an SGLT2 soon after that. Don't have them on those older therapies for too long. Once you're getting the glucose lower, introduce that SGLT2.
Would this be a Glixambi kind of patient? This is you go in straight with the DP4 SGLT2 so that they don't get as much polyuria. You know that the SGLT2 is going to lower him, but not too much, and you're going to need two agents. So why wouldn't you introduce two now, both of which won't make him lose weight, so you don't have to worry about catabolic losing weight. They're not going to make him dehydrated or a problem, and actually less glycosuria with the DP4 is going to help as well.
There's one word of caution I want to say. We also should rule out LADA, late autoimmune diabetes of the adult.
Yes, yes.
I always try to take the history of the weight, because if I have someone who seems to be very slim, it's not the typical type 2 diabetic German patient. And I frequently ask them, what was your highest weight? When did you change your weight? Because in some instances, very rare instances, you might have some kind of a type 1 diabetes patient.
And not as rare as you think. I mean, we have a specialized atypical diabetes service where we look out for MODIs and for LADAs, etc., and it's much more common than you realize. Perhaps not in the Asian population, certainly in the Western population, these atypical forms of diabetes can be a bit more common, but you're absolutely right. You've got to think about, is this actually really type 2?
All right. Another question concerning the DKA. I think that's a very important one. If you had a patient who had a history of DKA due to SGLT2, would you reintroduce the treatment, especially in patients with kidney disease? That's you.
Well, if a patient who had already a proven euglycemic DKA, I think I'd be very cautious in resuming this medication. I might really be considering if this patient is presenting with HFrEF. I might have to have a shared decision-making with this patient because of the increased risk of mortality in patients with HFrEF. And really, patients would die from euglycemic DKA, in contrast to patients with HFrEF. So in this context, maybe not, but in proven HFrEF, I think I will have to sit down with the patient.
Someone like this, again, it's risk versus benefit.
Yeah.
This person has proven themselves to be ketosis prone. So you can expect that in the future, if they ever got in the same situation, they might end up in the same way. But again, if you've got really bad heart failure or severe kidney disease, which is looming large on your mind, you might try and balance those things. One way that people have tried to do is make sure that that patients are really well educated in when to stop the medication, and also they go home with some of the urinary keto sticks, and that they are able to know that when they're unwell, they dip it, and if it's abnormal, they're stopping their therapy. Although there's recent evidence that SGLT2's effect on ketones can last probably at least 4 days. So stopping it right now can sometimes be a problem, but at least that gives some mitigation to it. So if you were desperate Keto sticks might be something that you can do. And in fact, many of our patients now have really cool glucose monitors that also the opportunity to buy a different kind of strip that they put into the machine to measure ketones as well.
And I remember Professor Wu mentioned really stopping the medications when there's an acute illness, right? I think that's an important advice that we give this particular patient, that every time he has an acute illness, he have to stop the medication.
Yeah, I think that I agree with absolutely everything that has been said, and most especially risks versus benefit. And there's one other thing that you have to consider in terms of the risk. What was the nature of the DKA? How did it come about? Did it come about almost out of the blue? Were they only just a little bit sick and they went into DKA? That person's very prone to DKA. But if this person was very ill, or if they were preparing for a colonoscopy and they weren't told to stop it, well, you've got a very obvious cause. And in that case, well, the risk of DKA may be much lower in the future. So you have to consider, how did the DKA arise and what is the risk of it reoccurring? And if the risk is low, in your opinion, I'd be using every opportunity to try and restart it with the various cautions and with the various precautions to try and prevent that in the future.
Very good. So one very last short question to you, Dr. Kino. Why would you not start the patient with aspirin or any antiplatelets as we discussed?
Okay. There was a trial that was really designed to answer this question. In asymptomatic patients with diabetes, would aspirin really modify the risk of a patient for future cardiovascular event? And the answer was, it didn't. So I think that's really the basis why I probably wouldn't do it routine. Okay. So that's the thing. I routinely do not give aspirin to many diabetic patients. There are, however, some caveats. Patients who are asymptomatic, but with screening, for example, would show silent ischemia, an old MI. These are not clinical confirmed manifestations, but these patients already deserve institution of an antiplatelet. Remember, one of you showed in your slide evidence of PAD being among the most common cause of presentation, right? And I think when we catch these patients, these are the patients we need to place them on antiplatelet. They don't necessarily have a confirmed coronary artery disease or a prior stroke, but they are protected from these in patients with PAD. And if I may add, a patient who is at risk for colorectal carcinoma, an addition of an aspirin may help this patient.
So it's always an individualized decision, because at the very moment we have to assess the balance, the risk and the benefits. Well, thank you very much for the great answers and for the great questions you gave. And I think we can conclude that session and we move on should we move on? Okay. We move on to the panel discussion about the holistic person-centered care. So this is a very important issue, because I think we did talk a lot about what we can do, but how can we get this to the patient? I mean, you and us, we discussed that the last 2 days, and I hope that we stimulated your thoughts, but how can we communicate that to the patient? Because the patient thinks, I have sugar, so I omit sugar, and that's good. And I eat more fat. So how do you explain to your patients the cardiorenal complex? Do you want to start?
Many times patients tell you their fear of dialysis. Sometimes they even visit you for an unscheduled reason. And the only reason is maybe because a family member died of a heart attack. So the fear of that, they tend to consult physicians. So that's an opportunity for us to remind them that, again, just like the eggs, if I may borrow your eggs, if I want to take care of that eggs, I'll protect it now. Now is the time. In fact, it was yesterday that I would have protected you. It's just that you came in today. So the early implementation of this should translate into actual protection if we do it early. So if we tell the patient, Because, it's really difficult because the patient wouldn't appreciate the benefit with the first dose or the second dose or the third dose. There's nothing that will improve in their symptoms immediately in the first week. But we need to tell them it's about the protection that they will get from taking the drugs.
How would you explain the cardiorenal metabolic problems to the patient?
It's a challenge because they are convinced that diabetes is if you like, a disease. I try and convince them that diabetes actually is a symptom of a bigger disease. That the same processes that have gone on that have damaged your ability to control your glucose levels and given you high sugars and diabetes is the same process that has been damaging your arteries to your heart and your legs, is the same process as damaging your kidneys and your livers. And by directing the therapy that I have towards not just one of those things, but all of those things is the best way forward. And that's why, convincingly, an SGLT2 inhibitor really is the first agent that is a cardiorenal metabolic drug, because it addresses all of those things. And the reason that I'm using this is not because of the sugar alone, or the kidney alone, or the heart alone, but because you have all of these things going on. You might show one symptom more than another, but it's all going on. And so treating holistically is really the way forward.
Anything you want to add on?
Yes, one last thing. There's some people who are very focused on numbers. And what I like to emphasize is that this is not a numbers game. What we're trying to do is that we are trying to prevent bad outcomes. And for different people, just as Dr. Aquino said, different outcomes are more important for some people than others. It may be dialysis, it may be amputation, it may be blindness, etc. And it's important for us as clinicians to find out what is the most important thing for that patient and to focus on how to prevent that bad outcome from happening. There's one last point that I think hasn't been mentioned, and it's the fact that a lot of these things are asymptomatic. And a lot of the patients say, I feel fine, therefore I am fine. And we need to impress upon the patient that many of these complications are asymptomatic early, but are only reversible early. Just as Merlin has said, when the eggs are broken, it's too late by then. What we want to do is we want to prevent the eggs from breaking in the first place. So we want to get onto these things before the patient even feels anything. And unfortunately, that's a bit of an uphill battle because people often treat symptoms only. If they feel good, they don't think that it needs to be focused on. So we need to focus their attention on the fact that they are at risk of these things from happening, and this is the most effective way that we can prevent that from happening.
One of the powerful things that you've got as a tool are the very many risk scores that you have. The color charts that say you're at high risk of a typhoon coming. You need to, watch and act and all those things like we have in Australia with bushfires. They understand that if I'm in the red zone, I need to do something about it. It doesn't mean that there'll always be a problem in the future, but it means that I need to act in order to prevent it. So with coronary disease, you have very validated, very clear risk scores that your patient's at risk. With kidney disease, we have heat maps that allow you to know my patient's at high risk of problems. With heart failure, there are emerging risk scores as well. And by putting those risk scores in front of our patients, we can leverage their adherence and leverage their understanding of why we want to prioritize organ protection, because you're at risk, right? Not for no reason at all, but because there's a warning that there's something coming in the future. We need to make an action now. Otherwise, we sail into the iceberg, start sinking, and go, why didn't we avoid those icebergs in the first place?
Yeah. In my previous life, I was a chief of an inpatient rehabilitation center. And we had so many patients after a heart attack, after bypasses, to come in inpatient rehabilitation. And very frequently, we newly detected diabetes in these people because no one really had looked for that. And when I discussed that with them, I always take an extensive family history in order to find out whether there is anything fishy. And very frequently you have strokes, you have heart attacks, but they are not connected to the diabetes. They are connected to smoking, to the stress. And when you try to figure out the family history, it happened to me several times. My father, did he have diabetes? No, he has the old onset, age onset sugar. That's diabetes. Oh, okay, yeah. But how old did he? How old was he when he died? Oh, he was 63. What did he have? Oh, he had a heart attack. He didn't die of the sugar. So the people's knowledge is very weird. And sometimes by taking the family history, not only I find out the risks in the family, I also do find out the perceptions the people have. And when we then, for instance, talk about someone ending up at dialysis, this is only because he smoked. And very frequently...
Because he survived, that's right.
Yeah, but I think this is one way to get into the communication with the patient, because you start to understand how the patient interrelates symptoms and disease factors. All right. The next question for us is, we have these great guidelines. How do we get the guidelines into the clinical use? I mean, first of all, it is on us to understand why we should go ahead. But then the patients also should understand, in particular, if you have to pay out of your own pocket. So what is your recommendation for that?
Well, after this meeting, I think when we go back to our clinics, every diabetic patient that you see, you ask, why is this patient not on an SGLT2 inhibitors or a GLP-1 receptor agonist? Ask yourself, is there really a valid reason that this patient should not receive one? Because guidelines are there, the evidences are already there. It's now a question of, as you said, why are we not using it? Do the patients deserve not to be protected from future cardiovascular and renal events? Do we need to see them undergo more dialysis, see the need for more renal transplant? You know, kidneys are not for free. Do you want to see more patients suffering from heart failure, having to need more hospitalization? And these are not just the morbidity and mortality, but the cost of the care. The issue of who's going to pay for it. We said it's costlier when we see patients in the hospital, but preventing them are really much better. So again, when we go back to our clinics, the moment we see a patient with diabetes, ask ourselves, why are we not giving an SGLT2 inhibitor?
So you take the question the other way around.
Right.
Why is he not? Is there any contraindication?
Right.
Okay. What about you?
So one of the nice things about guidelines is the way that they've pivoted over the last few years from being glucose-centric, sugar-centric, to now having their central pillar being, the first question is not what your A1C is, but what is your risk for developing cardiac problems, kidney problems, other complications as well. So the central pillar of management now is organ protection. But it's not the central pillar, it's not a pillar like you might imagine as they've drawn on the Greek ADA guidelines. No, the central pillar is more like the central pillar that you have in a pagoda like you would have in Japan, where, for example, in Kyoto, in an area that's prone to earthquakes, these pagodas have stayed for hundreds of years because they're built by a strong foundation and a central pillar, the Daikoku Bashira, a central pillar around which other pillars are built. So that if you build your management of diabetes around strong foundation of diet and lifestyle, a central pillar of organ protection, and then the secondary pillars of residual risk reduction, glucose, blood pressure, lipid, and weight, then you start building a kind of structure that goes for the future. And I think that the way that the guidelines have changed from being linear to being circumferential, starting off with the central core and the foundation that is strong, and then building in individualized risk reduction. So does this patient still have problems with glucose, blood pressure, weight, and lipids. And then beyond that, do they still have residual albuminuria or residual cardiovascular risk, to see what we can modify. But starting off with a central core really makes the if you like, the translation of guidelines so much more easy, because everybody's got a strong foundation. You're not building it, one down. You start everyone strong, and then you pick off the other things from that, depending on individual risk.
Look, I'd approach this in two ways. I think that they're clinician-based factors that we can focus on, and I think that they're patient-based factors that we can focus on to increase guideline adoption. In terms of the clinician-based one, perhaps I'll relate a slightly irrelevant almost story. When I was a lot younger, a doctor was lecturing to us saying, "Are you doing the right thing by your patient? Think about this. If it was your mother-in-law, would you prescribe this medication?" And I was thinking, oh, maybe that's not the right thing. Maybe I don't care what my mother-in-law is. Maybe, what is my mother? If this was my mother, what am I doing the right thing for this person? Am I doing everything that I can? Okay? And looking at the guidelines and making sure that you're familiar with the ever-changing landscape is obviously the first thing. But just think, is there something else that I can be doing? Am I doing the best? In terms of the patient-centric sort of factors, I think the biggest one that we cannot shy away from, of course, is access and cost. And I think that there's a couple of things that I'd like to say about this. The first thing is, just because as a clinician we think that the patient won't accept it, it doesn't mean that that's what the patient will do. You must always still have the conversation with the patient. This is now the best approach. Yes, it might cost a little bit more than what you're taking at the moment, but in terms of value for your future health, to preserve your function, not just to live as long as possible, but to live as healthily as possible, well, patients might surprise you. They might say, yes, I think that this is worthwhile. Also remind the patient that the complications are much more costly than the medication itself. Yes, the $50 or whatever it is for an oral medication may seem to be a lot, but imagine how much it's going to cost to be on dialysis or to have an amputation or to go into hospital for a heart attack. So the thinking about the cost of the complication needs to be kept in mind, not just the cost of acquisition of the product. And then finally, thinking about practical ways to facilitate the patients going on to these medications, whether it's about cost minimization or going on to fixed dose combination, which is more convenient, things like weekly administration, which is more acceptable than daily or twice daily administration of an injection. All of these factors, if you consider them, will help to increase acceptability of some of these newer best-in-class medications.
Well, I just want to add to all, which was very important, one other factor. We used the word staging yesterday, and I think in people with diabetes, when we are able to show that there is already beginning of damage, some eggs are broken, there is a slight decrease in eGFR. Don't wait till you're below 60. If there is a slight increase in albumin excretion rate, maybe you might even check for NT-proBNP. If there is any of this pathology, you have something to also explain to the patient. Listen, we do see you have retinopathy. We do see you have albuminuria. We do see, and this is the first and earliest sign for us that we have to be on the watch. And good news and bad news. The bad news is if we don't do nothing, there is an increased risk for heart failure, for heart attack, for kidney failure, and so on, and lots of costs. So then I think the patient is more ready to take the effort to be adherent, to pay for the medication, because we can explain to him that there is a risk you're getting to, an iceberg you're driving to, but there is a way around, and we have evidence-based help. And I think that is a positive message to the patient. We're not just making him fear, but we tell him, listen, we are under control, or we try to get under control. We do see that there's something happening, but we got to do something now. You don't sense it yet, but we have to do it now.
When you look at the psychology of why people undertake health-related behaviors, why they do what they do, take a medicine, accept things altogether, really there are three reasons. The first is value, that you convince them that this is a valuable thing to do, that it's not going to be harmful and it'll give you positive things. And that's worthwhile for some people who go on the basis of value. But some people go on the basis of another factor, which is confidence. You know, why would I take this if it's difficult or hard to do or will cause problems or difficult? So a lot of people feel unsure about new medications and new strategies, and a lot of doctors feel unsure about prescribing them because they don't have confidence. And what is really exciting about the medicines that we have now is that you can feel really confident that they work. We've got huge trials, we've got safety data, we've got different populations, the old, the younger, all sorts of things, when we know that these agents can be used very confidently. And the third most important thing turns out to be what's called norm. In other words, what everyone's doing. And so when we find that everybody's on an SGLT2 inhibitor, and all my doctors are prescribing it, and all my specialists are prescribing it, and all my GPs are prescribing it, then doctors will go and patients will go, well, why am I not on this medication? Because everyone's doing it. And so we need to drive change by making it entirely normal, not just for the odd cardiac patient to be on these agents, for all of them to be on it because it becomes standard of care. And so if we work on increasing the value of this agent by talking to risk, we talk about the confidence that you can have with these agents, and also the fact that the guidelines and every cardiologist and every endo and every nephro is going to be using it, then we can see people adopting this change more easily.
I remember during the time when statins were new, right? When statins were new, it were only cardiologists, specialists using statins. But nowadays, all of us are using statins. We were almost asking, why not put statin in water instead, right? I think now that we know about the benefits of SGLT2 inhibitors, why wait for a later time that we begin all of us using it? I think, again, that's why I said, there are so many patients who will benefit, and we need to find them. We need to use the right medications for them.
All right, that was a good word to finish this session. Thank you very much. And I think we're going to move forward for the question and answers. And the last 15 minutes are yours. Just go ahead and ask your questions. We already have a couple of questions. And let's start right away in patients with type 2 diabetes and sarcopenia and no CKD and CAD. Will they benefit of SGLT2 inhibitor? Who wants to take that? Actually, I've never heard the word sarcopenia as often as here. In Europe, no one would really talk about it. I don't know.
They talk about frailty, don't they?
Frailty in the very elderly. I don't know what is meant with that. Being an endocrinologist, you can have sarcopenia if you have not enough testosterone. So what is meant with that? Is that just frailty?
No, it's excessive weight loss. And, you know, there is sometimes a perception in Asian cultures that weight, especially when you're older, is a healthy thing. I think that sometimes that can be pushed a little bit too far. And I think that any weight loss, 1 or 2 kilograms of weight loss, that's not sarcopenia.
Yeah.
To an endocrinologist, sarcopenia is somebody who's wasted down to skin and bones and is losing multiple, you know, tens of kilos within a couple of months. That's what we mean by sarcopenia. So I think that we need to be realistic here. A couple of kilos of weight loss is not going to harm anybody. As long as your BMI is above 18, then that's not underweight. So unless you're talking about those really, really wasted people, then I think SGLT2 is still okay. And there's very good evidence that even in normal weight people, especially if they have complications, that SGLT2 is perfectly effective.
I mean, there's an ongoing study right now actually in Japan called the EMPA elderly trial that's specifically assessing using these agents and specifically assessing the effects on muscle.
Okay.
with respect to sarcopenia. So it is very topical and is something that is currently being assessed. On the other hand, a lot of people have been worried about GLP-1s and sarcopenia. That's been the, one of the, can't use this agent.
Yeah.
Is that an issue, or is that just
Well,
media hype?
I think that's a bit of media hype. I think where the rubber really hits the road is when we go to the double and the triple incretins, which are now showing almost 30% body weight loss. That's really sarcopenia. There were 2 or 3 kilograms with an SGLT2. That's not sarcopenia.
And we have the data of the heart failure studies in non-diabetics with almost normal weight. Nothing happened. So there's no risk for those people. And I think we always have to balance the risk and the benefits. And if you can preserve the kidney function, or if you improve the heart failure outcome, I mean, I know studies looking at the body impedance, at lean mass and fat mass, and they did show that it's mainly fat mass being lost. It's not lean mass. It's a little bit of water as well with SGLT2 inhibitors. So there was no major concern in the earlier studies when they looked at the weight loss.
No, absolutely right. So I presented one of these studies at our national conference, and it is indeed more fat mass loss than lean body mass loss. But at the end of the day, it's caloric loss, and caloric loss, whether it's by dieting or GLP-1 or SGLT2, is always going to lead to lowering of all body components, or body compartments, but with fat mass lost a little bit more than lean.
But there is one important issue. The weight loss doesn't go on, despite the fact that the people are losing glucose, and we don't understand that. So it's not that if you take an SGLT2 inhibitor, you go down the drain.
Correct.
So we do know that after a couple of 4 to 5 months, there's a level off, and the more obese you are, the more weight you lose, the less, or the normal weight, people, they lose 1 or 2 kilograms. All right, there is another question which I think is relevant. How can we detect euglycemic DKA in our offices?
Well, usually the patient is sick, That's why they got DKA in the first place. And often the manifestations of their sickness, be that COVID or gastrointestinal or had an MI or a stroke, usually they block your vision of what could be DKA. Sometimes they've also got just non-specific malaise, real tiredness, nausea, vomiting, and in particular, abdominal pain. And so they can present with abdominal pain and you go, oh, this is an acute abdomen, oh, there's something serious going on there. Remember to check the ketones in those sort of situations. But it's really hard to, usually they're sick for the other reason. And unless you have a degree of, thinking, could it be DKA, you often don't think. They may not have fever. So sometimes fevers are suppressed in patients with DKA compared to someone with an infection. It still may be infection, but their fevers might not be so profound. So anyone with diabetes that is sick, just always have a degree of, could this be DKA when they come in really sick to see you, and have the ability to do urine's not so good, largely because often they're dry and they don't make much urine. It's hard to detect. But often your clinic should have a glucose monitor that can do ketone sticks as well.
And I just caution one thing. Just because you find a little bit of ketone on a stick, that doesn't mean that they have DKA. So there's a gradation here. It's a spectrum from very little ketones to a few ketones, so that's ketosis, and then the clinical syndrome of illness of ketoacidosis is at the very high end. So don't panic just because a patient has a few ketones. All of us, presuming that we don't have diabetes, and even if we don't take any medications, we could have ketones. If we don't eat for 16 hours, if we do a lot of exercise, we will have ketones.
Some people want to have ketones.
Some people want to have ketones.
With
exactly.
a ketogenic diet.
Ketones is not bad by itself. However, the patient is then very ill, vomiting, they can't keep anything down, they have tummy pain, they're breathing very quickly. Those can be signs of ketoacidosis. And so if you measure that and the ketones are indeed high, then you might be treating for ketoacidosis. As for euglycemic ketoacidosis, Usually, in the classical sense, ketoacidosis is paired with a high glucose. In this case, the glucose is lower than you expect, but you can also have high glucose as well. I've seen many cases of DKA with SGLT2 where the sugar is 15. So it doesn't a high sugar doesn't exclude DKA from SGLT2.
All right. So we're gonna have to speed up because we have 4 more questions and a couple of minutes left. Is it safe to start a diabetic patient on SGLT2 who had been admitted for acute kidney injury secondary to an infection with high CRP and etc.? When would you restart the SGLT2 inhibitor?
When they're hemodynamically stable. Often you get AKI in these situations because you're really dry. You don't want to dry them out any further because that might risk problems. So the trials showing reductions of AKI are not in the acute setting, they are in the chronic setting. So I wouldn't start until they're hemodynamically stable.
All right.
But if the concern, if the patient may get another AKI when the patient becomes stable and you want to start this patient on an empagliflozin, we remember the data. Yeah, you showed it.
Absolutely reasonable to be adding this agent in as part of your care, but not in a volume unstable situation at the beginning.
Yep. All right. Can we use EMPA in patients with cancer other than kidney who are pre-diabetic?
What for?
Yeah.
Not for diabetes. So it has to be cardiac risk, heart failure indication, or kidney risk. So if you've got any of those things and you've got an indication for treating heart failure, HFpEF, cardiovascular disease, or for kidney disease in non-diabetic individuals, then you can. But again, someone with cancer and is very sick, the question is, what are you doing it for? They've got other problems often.
So there is the $5,000 question. How do we effectively explain the concept and benefit of reduction in all-cause mortality when using empagliflozin to our diabetic patients? Who wants to win the $5,000?
Why are the hands pointing at me? Look, I think everybody has their own way of explaining this, and everyone has their own language. My go-to one, and you may not agree, is that we've done a lot of studies, and people who took empagliflozin lived longer and died less than people who didn't, and we have proven that time and again.
I think it's sometimes necessary that we ask patients to imagine, like, until what age would he imagine him or herself dying? And sometimes you challenge, don't you think you will really be able to reach that age the way you dream it if you get the protection right now? I think that's something that patients will ultimately appreciate, knowing that the medication we've chosen is not just because of the sugar, it's not something just about the A1C, it's actually about the risk reduction and the survival of the patient.
All right. 2 more questions. One question, as mentioned earlier, there is an expected decline in eGFR due to a decrease in intraglomerular pressure, but up to what extent of eGFR decline can we go?
Don't measure it, then you'll never have to worry about it. Even in those individuals whose eGFR dropped by more than 30% within 4 weeks in all of the, for example, in the EMPA-REG outcome trial, which is a small percentage, like 1% drop, more than 30%. There were no signs of problems. There was the same cardiovascular benefits. Don't measure it, then you don't have to worry about it. And obviously in the long term, kidney function decline is important, but in the short term, you just don't need to look for it because in no way does it reflect the ability of this agent to either work or their risk of toxicity.
Yeah, indeed, the rates of AKI are always lower in the empagliflozin arm than in the placebo arm. So there's less kidney injury, not more.
I remember in the EMPEROR program, the trial design was that even if, because we know heart failure patients are at risk for cardiorenal syndrome, even if they went into hemodialysis, they didn't stop the medication. And what the results showed, there was benefit.
Yep. I mean, the most important issue again is that the drug is not toxic to the kidney. And the reason why we had this stupid contraindication was due to those sugarologists. And now we have totally different other indications. So the very last question goes into the future. Can you consider using SGLT2 inhibitors in obese non-diabetic patients who do not tolerate metformin?
I think I would prefer to wait for studies for use of SGLT2 inhibitors in pre-diabetes.
But there were plenty of those people in the EMPA kidney trial. There were plenty of those people in the EMPEROR trial. And so if you've got...
You have this indication.
Yeah, if you've got heart failure, if you've got kidney disease and whatever,
There's
if you've got
no question.
pre-diabetes, diabetes, no diabetes at all, you should be on this agent. So it really depends on why you would use it, what risk you have, and certainly patients with pre-diabetes. In fact, most excitingly, patients with pre-diabetes getting these drugs in these trials actually had a lower rate of developing diabetes as well.
Right.
Not that it's indicated for that, but that's kind of a cool thing coming up.
That's right. So you know, the final politically correct thing to say is that there are no medications at the moment which are indicated to prevent the progression to diabetes from pre-diabetes. Lifestyle is still key. The future, we don't know, maybe. But as we stand here in 2023, there are no medications indicated in pre-diabetes for prevention of diabetes.
But there are medications to treat people with CKD and
Yes, that's
heart
right.
failure. And,
Yeah.
Okay, well, thank you so much for this interesting discussion. Thank you for all your questions. And I'm going to go over there. Oh, no, I can say here. Good. So, ladies and gentlemen, we did talk about the cardiorenal metabolic cooperation. I mean, we did talk about the symptoms, but we need the cooperation. And let's just rethink what we have been doing in the past. We have the genes, we have the lifestyle, then all of a sudden we have a vascular burden, and then we might have vascular and renal events. This is where the diabetologist pops up quite late, and even later the cardiologist, and much later the nephrologist. You, as family physician, you are there all the time. And I think we have to rearrange everything. I think we have to start out earlier. We don't need sugarologists, and I call them the metabologists, because we need to look at prediabetes, at obesity, at lipids. We need to have the cardiologists and the nephrologists to join us early enough to prevent all these massive complications to happen. And maybe in the future we will also have a hepatologist with us who helps us to treat fatty liver. But we all need to get up earlier to detect these patients and to prevent them from getting into the complications. And therefore the cardio-metabolic renal cooperation indeed is very much needed. And it's not that the cardiologist is more important, or the nephrologist, or the family doctor, or the endocrinologist. We all need to get together to improve the patient's outcome. So let me wrap up the 5 takeaways. We did talk about the cardiorenal metabolic risk factors, the complications, and I called it a malignant disease with a shortened life expectancy and quality of life as well. So this is the bad news. But we have learned that the multimodal intervention and that the newer agents can really make a change. They improve the outcome, the quality of life, and also at the long run, the costs. So this change of paradigm has been published already billions of times. It's in all the guidelines, consistent all over the world. But we have this inertia, in particular of the doctors. The patients need to be educated, as we discussed, and we have to overcome that by education, interdisciplinary discussions and talks and symposia with the physicians, but also for the patients. And we might need some plans to really get going. We need to check for UACR at least once a year. We need to check for EGFR and check it over the time and all those things. And last but not least, yes, we have to get up earlier, as we did say. We need to detect. We talked about staging, and then we have to act. and we have to control. And there are many things we can do. It's not only glucose, it's blood pressure, it's lipid, and the prescription of drugs which have a proven benefit on the heart and on the kidney. And we learned a lot about empagliflozin being a great drug, not only to improve the kidney and the heart outcomes, but also reduce mortality. But that cannot reduce mortality if you don't prescribe it. And here we are back. It's on us to prescribe the drugs to the right patients. I thank you very much for your great contributions. I thank you for your attendance. And I thank Boehringer Ingelheim for supporting us. And I wish you a good weekend and a safe travel home. Thank you.
Thank you to our esteemed speakers for a very insightful discussion. All participants are requested to complete and submit the evaluation form, which you can access through the QR code flashed on your screens. Or you may go to Slido and use the same event code #Connect to access the survey form.